If it is not bulky, we can go for straight away gastrectomy with D2 lymph node dissection. If it is bulky, we will go for NAC followed by surgery. And then if the disease is metastatic, then the management differs. That we will read in some other class. So after gastrectomy, if the stage is pathological stage is 1, we will observe. Stage 2, 3, excluding T1, T3, subserosa, we will give adjuvant chemotherapy, and stage 4 we can give chemotherapy if the patient can tolerate or best supportive care. So now there are types of or definitions of gastric surgery. So standard gastrectomy and non-standard gastrectomy are two types. What is standard? Standard gastrectomy is the principal surgical procedure performed with curative intent. It involves resection of at least 2/3 of the stomach with D2 lymph node dissection. And these D categories we will read further. Non-standard is, in non-standard gastrectomy, extent of resection or lymph node dissection is determined depending on the tumor stage. So these are either modified surgeries or extended surgeries. So modified are less than standard, and extended, as the name tells, they are more than the standard. So what is the definition for modified? Extent of gastric resection and or lymphadenectomy is reduced compared to the standard surgery. Extended surgery is more than the standard, like multi-organ dissection or lymph node dissection beyond the standard procedure. Then non-curative surgery. Non-curative surgery is offered to the patients who are considered incurable. It can be semi-classified into either palliative or reduction surgeries. So palliative, like we do for gastric outlet obstruction or the tumor is bleeding much, we can do such type of surgeries. Reduction surgery is simply debulking surgery, and it is not proven beneficial in any trial, so it is not the norm of, we cannot give this option in the current scenario. This is for study purpose only. Then extent of gastric resection. So total gastrectomy. First one is the total gastrectomy, total resection of the stomach, including the cardia and pylorus. Then distal gastrectomy, stomach resection including the pylorus. The cardia is preserved here. In the standard gastrectomy, 2/3 of the stomach should be resected. Then pylorus preserving gastrectomy, stomach resection preserving the upper third of the stomach and the pylorus along with the portion of antrum. So this will be known as pylorus preserving. Proximal gastrectomy, stomach resection including the cardia, G junction, the pylorus is also preserved here. So what is the difference? In this, upper 1/3 is also preserved in pylorus preserving, while in proximal gastrectomy only pylorus is preserved. Then segmental gastrectomy, circumferential dissection of the stomach, preserving the cardia and pylorus. Like only one segment we remove. This will be known as segmental gastrectomy. And local resection, when we remove non-circumferential part of the stomach, it will be local resection. Non-resection surgeries like bypass surgeries, gastrostomy, jejunostomy and all. In addition, surgery for cancer of gastric remnant, like some surgery was done, the disease again came, then we can also do surgeries on gastric remnant. That will be completion gastrectomy if we remove the remnant totally, and subtotal resection of the remnant, that we still leave some part of the stomach. Then extent of gastric resection. What should be the resection margin? So here we are talking about the proximal resection margins. So proximal resection margin should be at least 3 cm. For which cases, either it should be T2 or more than T2 and type 1 or 2. That Borman type we study, Borman classification of the gross visual classification of the tumor. Like T1 will be protruded, T2 will be ulcerated, T3 will be ulcero-infiltrative, and T4 will be diffusely infiltrative. So if the tumor is T2 or more than T2 and type 1, 2, we have to take 3 cm proximal resection margin. If the tumor is type 3, 4, then we have to take 5 cm of the proximal resection margin. However, we cannot put this, if we cannot judge the depth of invasion, or we are finding some difficulties, we can always use the frozen section. For tumors invading the esophagus, a resection margin more than 5 centimeters is not needed. Previously, it was suggested that if esophagus is involved, we should take more than 5 centimeters. Now, this is not a norm. We have to take adequate margins and it for frozen. For T1 tumors, a gross resection margin of 2 centimeters should be obtained. When a tumor border is unclear, difficulties in deciding on dissection line are expected. Preoperative endoscopic marking of the border by clips can be done, taking along with the biopsies. So 3 types of margins are there: 2 centimeter, 3 centimeter, and 5 centimeter optimal margin. 2 we will take for T1, 3 we will take for T2 or more, but only Borman type 1 or 2. If Borman type 3 or 4 is there, we will take 5 centimeters. Then selection of gastrectomy. The standard, as we all know, surgical procedure for clinically node positive T2 to T4A tumors is either total or distal gastrectomy based on the location of the tumor. So distal gastrectomy is selected when a satisfactory proximal resection margin can be obtained. When obtaining a clean proximal margin is not possible, total gastrectomy is selected. Even in case with a satisfactory proximal resection margin can be obtained, pancreatic invasion by the tumors that requires pancreaticosplenectomy, we have to go for total gastrectomy straight away. Then we cannot go for DRG. If pancreas is involved and we have to perform pancreaticosplenectomy, we will do total gastrectomy regardless of the location. So total gastrectomy with splenectomy should be considered for tumors that are located along the greater curvature. Should be considered. Like if the tumor is infiltrating the hilum or spleen, we can do splenectomy. It is not a norm, but should be considered if the tumors along the greater curvature are infiltrating the hilar area. For adenocarcinoma of the esophagogastric junction, proximal gastrectomy is also considered. For clinical T1 and 0 tumors, the following types of gastric surgeries can be done. Pylorus preserving we can do for the tumors in the middle portion of the stomach with distal tumor border at least 4 centimeter proximal from the pylorus. So we can at least leave 4 centimeters from the pylorus, then we can plan for this. Proximal gastrectomy for proximal tumors where more than half of the distal stomach can be preserved. And local resection of the stomach and segmental gastrectomy should still be regarded as investigational treatments. These are not standard of care, can be performed under only clinical trial conditions. So what was local resection? It was just wide local excision. We do not remove anything else than a wedge of the stomach. What is segmental? We just remove circumferential segmental, as we already discussed. So now we will read about the extent of lymph node dissection and definitions vary according to the type
that
of
we
surgery.
do for the gist ना डॉक्टर राकेश?
Yes ma'am.
जिस्ट में करते हैं वो.
हाँ, अपन तो सीए स्टमक का बोल रहे हैं.
वही मैं बता रही थी, इंडिकेशन है उसका, जिस्ट में करते हैं.
हाँ. Okay, so definitions of D level will be according to the type of gastrectomy. So with total gastrectomy, D0 will be lymphadenectomy less than D1. It will be known as D0. Then what is D1? We have to remember this. For total gastrectomy, D1 is node 1 to 7. So quickly can we revise it? What is node 1? Right pericardia. What is 2? Left pericardia. 3 and 4 are along the curvature, lesser curvature and greater curvature. And 5 and 6 are along
suprapyloric and infrapyloric.
7 is
left gastric.
So for total gastrectomy, this will all blue nodes will incorporate into D1. Then what is D1 plus? So we can remember it 1 to 11P except 8P and 10. So this will be excluded in almost everywhere. 8P and 10, that is hilum. 8P is posterior. So we can remember it like this way: 1 to 11P, only leaving 8P and 10 for total gastrectomy. And what will be D2? 1 to 12A except 8P and 10. So this will be D2 for total gastrectomy. Tumors invading the esophagus, resection of nodes 19, 20 and 110 should be added. That we studied that along the subphrenic artery, in the esophageal cardia, in the lower mediastinum.
4SA क्या हुआ रे? Short gastric.
4SA short gastric arteries.
ठीक है.
So total gastrectomy D1 is 1 to 7. If we remove 1 to 6, what will be it? D0. Less than D1 is D0. So D1 will be 1 to 7. D1 plus will be 1 to 11P except 8B and 10. D2 will be 1 to 12A except 8B and 10. So for DRG, D0 is less than D1. What will be D1? So we can remember it based on like this. D1 will be 1 to 7 except 2 and 4 SA. As we are doing DRG, distal radical gastrectomy. So why will we?
या उसमें तो 1 नहीं बचता. हाँ 2 और 4 बचता.
हाँ, along the lesser curvature तो we remove ना.
हाँ, from lesser curvature we remove all lymph nodes.
Because already we are tying the left gastric artery. So we can take all that thing. So we are leaving the nodes along the upper part of the body along the greater curvature. That is 2 and 4 SA. This is D1 for DRG.
4 SA का कोई वो है क्या आपका, मतलब कोई क्राइटेरिया कि कहाँ पे कट लगाना है?
शॉर्ट गैस्ट्रिक आर्टरीज के लो.
शॉर्ट गैस्ट्रिक आर्टरीज के लो, वहाँ तक तो जाते ही नहीं है ना, उधर तक तो पहुँचते ही नहीं हम.
हाँ, तो वो रह जाता है.
ठीक है.
So this will be D1. Then D1 plus is 1 to 9 except 2, 4 SA is already there. 8P we never remove. We already discussed. So 8P. So D1 plus will be 1 to 9 except 2, 4 SA and 8P. Then what will be D2? D2 will be 1 to 12A except 2 and 4 SA we have already excluded because of the procedure is limited to the distal stomach only. 8P and 10 we already discussed that we never remove them. And then 11D, that is along the distal part of the splenic artery. So these we also leave in DRG. Like you can remember the way you find it easy. I just told you how I did it. Then pylorus preserving gastrectomy, D0 will be less than D1. D1 will be DRG minus level 5. So D1 for DRG is 1 to 7 except 2 and 4 SA. So if we leave the level 5 also, it will be D1 for pylorus preserving gastrectomy. There is no D2 in pylorus preserving gastrectomy. So DRG minus level 5 will give us D1 and D1 plus for the pylorus preserving gastrectomy. Now proximal gastrectomy. So proximal gastrectomy, we are removing the proximal part of stomach only. So as we all know, 3B is along the branches of right gastric artery. 4D is along the right gastroepiploic artery. And 5 and 6 are near the pylorus. So we are not going to touch this area. So we are leaving all these nodes. D1 will be, all the nodes will be removed as we remove in total gastrectomy, just leaving the nodes 3B, 4D, 5 and 6. Likewise, D1 plus will be as we remove in the total gastrectomy, leaving the above mentioned lymph node levels. D2 will be total gastrectomy as we mentioned, minus all these nodes plus 12A. 12A also we leave in this because 12A is in the HDL along the hepatic artery. So we are not going there also. So this is for proximal gastrectomy. So they are like too much, maybe little bit complicated. We will give 2-3 readings that we can memorize them. For tumors invading the esophagus, station 19, 20 and 110.
Usually we are doing proximal gastrectomy for G junction tumor only ना.
yes.
तो 19, 20 और 110 आ ही जाएगा उसमें.
If the invasion of esophagus is there.
वही G junction को तो क्या बोलेगा, इसोफेगस तो रहेगा ना थोड़ा बहुत.
Further we will discuss there are 3 categories less than 2 centimeter invasion, 2 to 4 or more than 4.
अच्छा.
तो आगे आएगा.
I think in this lymph node station we understand how much dissection we do in the stomach. We will think how which nodes will come on the vicinity. And we will come to know which way. Yeah, the farther nodes we have to leave. If we analyze the previous, how much stomach we remove, like proximal, what are the vicinity nodes?
Yes.
That will come under D2. Yeah. Far away nodes will automatically go out of D2.
Yes.
Similarly, distal also, whatever the vicinity vessels are on the D2, that will come under D2. Proximal, like the short gastric. The short gastric vessels will be far away nodes from the distal gastric. For example, there is an antral growth. Yeah. The short gastric nodes are far away. They won't be included into D2. Likewise, in proximal gastric, the short gastric vessels are nearby. They will be included.
Yeah.
Like that ways. The far away, for example, HDL nodes are far away from the cardia. So they won't be included in the D2.
पर पता है हम लोग क्या करते हैं डिस्टल गैस्ट्रेक्टमी कर रहे हैं, DRG कर रहे हैं, ट्यूमर देख लिया कहाँ पर है, ट्यूमर से 5 सेंटीमीटर मार्जिन है सफिशिएंट, ठीक है. फिर ये जो 4SA और 4SB वाला कॉन्सेप्ट है ना कि कहाँ से 4SA शुरू हो रहा है, कहाँ से 4SB शुरू हो रहा है, वो नहीं देखते. लेसर कर्वेचर का पूरा नोड निकाल लेते हैं, पर ग्रेटर कर्वेचर पे ये 4SA और SB वाला जो है ना, ये मैं को
we go there now, like this is the point, right gastroepiploic is coming and left gastroepiploic is coming, this is the junction, है ना. So we divide the stomach here na along greater curvature, like they have divided.
Yeah. See, for antrum, for this right gastroepiploic is a close by nodes.
So this also has one term, von Gitti point. This junction of the right gastroepiploic and left gastroepiploic, this is known as von Gitti point. GHOET, von Gitti point. Yeah, continue. You were telling something.
Yeah, similarly that actually this short gastric vessels, I'm again repeating that it is a D2 node for proximal because it is nearby.
Yes.
Likewise, it won't be as close for distal gastrictomy. Yeah. Similarly, if you see, if you go a bit down to proximal gastrictomy, you kindly scroll down a bit, proximal. Kindly scroll down, yeah. Proximal gastrectomy, you see, the 12 in D2, they are not included in proximal because that is very far away. Why to go there?
Yeah.
But if you scroll down back, go down the back. Yeah, wait. For distal gastrectomy, they have included 12 because it is nearby. Okay.
In the vicinity.
In the vicinity. So if you just imagine near the picture, the vessels, you can guess, although you cannot accurately, but you can just
we can just have a overview, but we have to remember for the practical purpose and for clinical discussion and all. So okay, should we proceed?
Yeah, please.
So now number 1110 lymph nodes, that is lower thoracic paraesophageal node in gastric cancer invading the esophagus, are those attached to the lower part of esophagus that is removed to obtain a sufficient resection margin. Okay, and for pylorus preserving one point is there that D level should not be changed in case in which number 6I was incompletely dissected in pylorus preserving gastrectomy. If we remove some part of it, that will also be considered adequate. Then indications for lymph node dissection. In principle, D2 lymph adenectomy is indicated for clinical node positive or stage T2 or more than that, and D1 or D1 plus for clinical T1 N0 tumors. Since pre and intraoperative diagnosis regarding the depth of the tumor invasion, nodal involvement is difficult at times, and it is like we can guess it, but we can never tell it correctly. So D2 lymph adenectomy should be performed whenever the possibility of nodal involvement cannot be dismissed. So what is D1? D1 lymphadenectomy is when it is indicated. D1 is indicated for clinical T1A tumors that are well differentiated and less than 5 centimeter or smaller in the diameter.
ये तो कभी नहीं आते.
Then D1 plus. D1 plus is indicated for clinical T1 and 0 other than the mentioned criteria for D1. Then D2, most of times we are going to perform D2 for node positive, clinical T2 to T4, we are going to perform D2. So the spleen should be preserved in total gastrectomy for advanced cancer of proximal stomach provided the tumor does not invade the greater curvature. Now, when we will do D2 plus, these are not proven by any level 1 evidence, but these are practiced. So it has been mentioned in the guideline. They have also written that the evidence is lacking. So dissection of number 10, that is splenic hilar node, with or without splenectomy for cancer of proximal stomach invading the greater curvature, we can perform level 10. Dissection of 14B, that is superior mesenteric vein, for cancer of distal stomach with metastasis to number 6. What was the number 6 station?
Infrapyloric.
Yeah. So if the nodes, we can send it for frozen also, and if we are having clinical suspicion that the level 6 is involved.
या सुपीरियर मेजेंट्रिक तक हम कैसे पहुंचेंगे डॉक्टर राकेश? ऐसे में 6 तो मेरा बहुत बार पॉजिटिव रहता है क्योंकि
वो उधर भी आ जाएगा ना, मोबिलाइज करेंगे, कोकराइज करेंगे तो नीचे मिल जाएगा.
कोकराइज करना पड़ेगा यार, मैंने नहीं करा.
अब क्यों करना कभी. चलो 14V is along the superior mesenteric vein when we have to perform distal stomach metastasis to number station 6. Then when to do station 13? Station 13 is posterior pancreatic head nodes or the cancers invading duodenum. We have to perform the station 13. There is one important line that number 13 nodes are among the regional nodes for that cancer of duodenum. For stomach, they are metastatic. But if the CS stomach is directly infiltrating or invading the duodenum, then it can be considered as regional node.
ठीक है ना, कभी कभी D1 तक जाता है ट्यूमर.
हाँ. Then dissection of number 16, that is abdominal aortic lymph nodes. After neoadjuvant chemotherapy, if pre-chemo nodes were there, we have to perform these also. Then comes the esophagogastric junctional cancers. So the current guidelines of Japanese gastric cancer treatment guidelines defines the extent of lymphadenectomy according to the type of gastrectomy, regardless of tumor location. However, only for esophagogastric junctional cancers, either adeno or squamous, center is located within 2 cm of G junction. There is no consensus on type of dissection, extent of lymphadenectomy as standard cure. So in this, they published this time the edition, and also some discussions are already going on there. So they found that the incidence of lymph nodes metastasis differed according to the length of esophageal invasion. A low incidence of mediastinal lymph node metastasis in tumors with esophageal invasion less than 2 centimeters, especially less than 1 centimeter. A high incidence of lower mediastinal node, that is station 110. So lower mediastinal involvement will be higher if tumor is 2.1 to 4 centimeters. But till 4 centimeters, there are low chances of involvement of upper and middle mediastinal. If the invasion of esophagus...
Please mute everyone, mute please. मोहन म्यूट.
मोहन भाई,
मेरा नहीं है भाई.
नहीं है क्या?
सब्जी बेच रहे हैं क्या?
चलो ओके, तो 2 सेंटीमीटर से कम है अगर इसोफेजियल इन्वेजन तो देयर आर लीस्ट चांसेस. 2 to 4 है तो स्टेशन 110 और लोअर मीडियस्टिनम विल बी इन्वॉल्व, कैन बी इन्वॉल्व. अपर एंड मिडल का चांसेस कम होगा. इफ इट इज ग्रेटर देन 4 then there will be chances of involvement of the upper and middle mediastinum also. So now how to perform the lymph node dissection. If clinical T2 to T4 junctional cancer and esophageal infiltration length is less than or equal to 2 centimeter, we will perform the lymph node stations as we are doing in proximal gastrectomy plus station 19. What was station 19? It
Paraesophageal.
was subphrenic artery, along the subphrenic artery. So we go towards the hilana. Already we have to mobilize it there. We have to remove this also. So less than 2 centimeter, there is no need to remove mediastinal nodes. If it is 2.1 to 4 centimeter, then we will remove 110, that is lower mediastinal paraesophageal lymph node also. If it is more than 4 centimeters, then we have to remove station 106 to 112. That will incorporate the middle and upper mediastinum.
तो ट्रांसथोरेसिक करना पड़ेगा.
For these, like this is the 1/10 we can take. Sometimes if there is some difficulty, then we have to go transthoracic. इसको मिटाता हूँ मैं तो दिखेगा. They have mentioned transhiatal. For this we can do transhiatal approach. For this it is plus minus. For this for sure we have to go transthoracic.
इनका नाम पढ़ा था क्या अपन ने 106 से वाले का? नहीं याद आ रहा.
ये तो अलग से भी देखने पड़ेंगे. बताऊं क्या?
पहले कंप्लीट कर लो फिर बता. हो गया और है
वो होता है
थोड़ा सा है.
thoracic paratracheal lymph nodes होते हैं, left pretracheal, tracheal bronchial और right tracheal.
ये so 106 is along the recurrent nerve. राइट साइड का है, राइट 106 recurrent R हो जाएगा. ठीक है. 109 is
नहीं दिख रहा. नहीं आ रहा
इमेज. ठीक है, फिर ग्रुप में भेज दूंगा. ओके, अभी दिख रहा है स्क्रीन?
स्क्रीन दिख रहा है आपका.
ठीक है. Then some miscellaneous topics are there like vagal nerve preservation. So it has been reported that preservation of the hepatic branch of the anterior vagus and celiac branch of the posterior vagus contributes to improve the post-operative quality of life by reducing the gallstone formation, diarrhea and weight loss. So we should attempt to preserve it when possible. Omentectomy. Removal of greater omentum is usually integrated in the standard gastrectomy for T3 or deeper tumors. Chances of involvement of level 110. So now there are debates that up to 4 centimeters we can safely go with the transhiatal approach. And transthoracic approach, if the higher level of nodes are going to be involved or clinical suspicion is there, we have to go transthoracic. Then what are the evidences for laparoscopic
कैसे क्लिनिकली देखनी है कि रेडियोलॉजिकली देखनी है? कैसे देखेंगे?
क्या मैम?
ये लेंथ पाल्पेट करके डिसाइड करेंगे कि रेडियोलॉजिकल देखेंगे? कैसे डिसाइड करेंगे?
रेडियोलॉजिकल आइडिया लग रहा है तो अच्छा है, नहीं तो इंट्रा पाल्पेशन और फ्रोजन के लिए भी भेज सकते हैं डाउट हो तो. ये तो
4 सेंटीमीटर और 3 सेंटीमीटर स्केल से तो नापता नहीं है ना अपन लोग. ये मैं सोच रही हूँ.
वो तो अपना जैसे पहले स्कोपी करेंगे ना बिफोर, मतलब अपन जो मैपिंग करते हैं ट्यूमर में, पर जो एंडोस्कोपी से आइडिया लग जाएगा.
ठीक है.
So for laparoscopic surgery is better or less, or what is the status? So for clinical stage 1, it is the standard of care. We can safely perform the laparoscopic surgery. For advanced gastric cancers, there is one trial, that JLSSG0901 trial. इसके रिजल्ट आ चुके हैं. वो रिजल्ट बोलते हैं कि अंडर if some expert is doing the case, for advanced cases, even there is no difference between open and lab DRG.
कितने केसेस करने के बाद एक्सपर्ट बनते हैं?
पता नहीं, मतलब उन्होंने तो अपना जापानीज गाइडलाइन मान के कुछ कुछ मांगा है कि इसमें सर्टिफिकेट होना चाहिए, उसमें सर्टिफिकेट होना चाहिए. ऐसा एज ए नॉर्म कितना है पता नहीं. Then reconstructions, as we all know, after total gastrectomy, Roux-en-Y, EJ, jejunal interposition, double tract. After distal gastrectomy, Billroth 1-2, Roux-en-Y, pylorus preserving gastrostomy. For proximal, we do esophagogastrostomy, jejunal interposition, and all. Endoscopic resection, I will discuss next time. Thank you.
बहुत ज़्यादा ही हो गया था वैसे भी.
Thank you.
इसको बनाना भी.
इशफाक, अवनीत. अरे अवनीत.
हाँ मैं हूँ.
लास्ट में प्रेजेंट कर रहे हो. ईसोफेगस स्टमक सेम हो जाएगा, मिक्स हो जाएगा.
थोड़ा सा मिक्स वो भी है, ओवरलैपिंग भी है जो मैं और डॉक्टर राकेश प्रेजेंट कर रहा हूँ.
तो इशफाक को बीच में ले लो.
रिवीजन हो जाएगा. ठीक है.
इशफाक को बीच में ले लो. नहीं
क्या बीच में क्या कोई कहीं जा रहे हैं क्या?
अरे मतलब ईसोफेगस स्टमक के बीच में थोड़ा गायनिक टॉपिक हो जाएगा तो स्प्लिट हो जाएगा दिमाग.
As you wish.
बाकी लोग क्या बोलते हैं? मैं अकेले ही बोल रही हूँ.
चलेगा, हम लोग ऐसा कुछ नहीं है, कर सकते. रिवीजन हो जाएगा.
बना दो. चलो किसी को बना दो. I think we are a few years back. So as we know, surgery is the mainstay treatment. THBSO plus pelvic lymph node plus parietal lymph node dissection. Selective lymph node dissection is based on Mayo criteria. Show high sensitivity and low specificity, around 80% for high risk patient undergoing extensive lymph node dissection. So what are the disputes in lymph node dissection in the endometrial cancers? They say that therapeutic role and survival advantage of lymph node dissection is controversial, especially study by Bulgari et al. Demonstrating that lymph node dissection brings no survival benefit in intermediate risk endometrial cancers, and other studies have shown the same result. At present, selective lymph node dissection is utilized by Mayo criteria. What they say, if the patient is having endometrial grade 1, endometrial grade 2, myometrial less than 50% invasion, tumor diameter less than 2, better to omit the lymph node dissection. This is called Mayo criteria. Concept of similar SNB, I do not need to describe. If septal lymph node is found on frozen section, lymph node dissection can be performed directly during the surgery. If hematoxylin eosin staining plus minus at last staging of central lymph node is positive after surgery, patient have choice of adjuvant or second surgery. So a bit history that 1960 Gold et al. First discovered and defined what is central lymph node in parotid CA. Mohan Bhai must be knowing better than me regarding the evolution of central lymph node. So I will go just to detection method. We have blue dye. We have blue dyes are methylene blue, isosulfur blue, patent blue. Radioactive tracers are actually 4 detection methods, sir. One is dye method, other is radioactive method, technetium 99. It remains concentrated in central lymph node, emits gamma radiation, which can be detected by gamma detector and SPECT CT. Radioactivity can transmit the signal through the deeper tissue. So no need to cut, we can visualize outside where the tracer is. But only problem with this radio tracer is cost, equipment. And other problem in endometrial cancers has been seen that while injecting it into the cervix, it creates a confusion whether the cervix is highlighted or parametrial node is there. As we know, the ICG is nowadays becoming gold standard. Not a gold standard, but most preferred method. It is a near infrared fluorescent dye is injected through the lymph node, and infrared, which emits infrared light at 700 to 900 nm. Most recommended tracer. Then one new addition is the carbon nanoparticle. These are very small, 150 micrometers particles that have almost diameter of the lymphatic system and are taken up by macrophages. It's excreted through respiratory system with advantage of unique lymphatic system tendency in small size, fast diffusion, and long-lasting color, rendering with no adverse reaction till reported. So these were the tracers. Now, injection route. Cervix is the most commonest and simple way to, because cervix is rarely deformed. Anatomical studies have confirmed that cervix injection can penetrate into deeper uterine vessels, stomachs, parametrium, and uterine body, while deep injection can reach up to parietic nodes. We can do uterine body or corpus injection via hysteroscopy guided and transvaginal ultrasound guided, either peritoneal given intra or perioperatively, subserosal or myometrial injections intraoperatively. RCT showed hysteroscopic injection has a higher rate of identifying parietic nodes than cervical injections. So, if we give cervical injection, the chances of getting these pelvic nodes are more, but if you give injection around the corpus, the parietic node identification becomes more. Hovier et al. Conducted systematic review of cervical injection and corpus injection. And cervical injection, you can see 60 to 70% is the detection rate, and corpus is 70 to 90%. So if we give the parietic node detection is 40% in fundus if you give injection, 15% deep cervical, and 2% superficial cervix. So you can see if you want to detect the parietic nodes, the cervix is not a good option. So diagnostic accuracy, as we know the diagnostic accuracy, what is the accuracy? It is increased sensitivity, increased specificity, decreased false negative rates. This is the SENTI-ENDO trial conducted by Derai et al. For central lymph node dissection and lymph node dissection was performed in 125 patients with FIGO 1/2 endometrial cancers. They found the sentinel lymph nodes has a detection rate of 88%, 84% sensitive, negative predictive value 97, false negative rate 2.5. Improve the sensitivity and negative predictive value, MSKCC proposed bilateral lymph nodes should be added if sentinel lymph node fails, because it will add to the statistics analysis. All suspicious nodes should be removed. Ultra-staging should be performed. If you add to this your surgery, your sensitivity and negative predictive layers will be better defined. Long et al. Did meta-analysis in the central lymph node biopsy of endometrium. They showed detection rate 75% and has an increased learning curve and sensitivity 93%. What are the factors affecting diagnostic accuracy? First is surgeon's experience. Ori et al. Suggested 30 cases play an important role. After that, the detection rate comes up. And other factors, tracer type and injection site. ICG plus cervical cervix is the recommended. Cabrera et al. Added technetium 99 ICG. Both we showed increased bilateral detection rate. Others in this study added carbon nanoparticle plus ICG. Cervicus reinjection can be done again if mapping failure occurs. If you do again cervix injection, your bilateral detection rate, diagnostic results improve. Third factor is patient's condition, age, BMI 40, adhesions, lymphatic vessel obstruction, or filariasis could impair your diagnostic accuracies. Sentinel lymph node do not impair survival outcomes. Senti-endo trial study showed the outcome of 125 patients with stage 1 to 2. There is no difference observed in the recurrence rate and recurrence-free survival between successful sentinel lymph nodes and failed group. And they showed sentinel lymph node reduced the intra and post-op complications. So what is the current application of sentinel lymph node mapping? NCCN recommends application of sentinel lymph node in endometrial cancer with lesions confined to uterus without mets, and also permits the use in high-risk early serous, clear and carcinosarcomas. When mapping fails, we have 4 options. What are the options? Wait and watch. Something highlights. Second is exploring uncommon sites like presacral, common iliac, para-aortic. Third option is urea injection as per previous trial. Fourth is performing site-specific lymph node dissection. What are the controversial issues? Ultra-staging is combination of several series of hematoxyl elucin sections plus IHC of the node, that's anti-keratin AE1, AE3, to identify LVMD, that is low volume metastatic disease. What is low volume metastatic disease? As we know, macrometastasis is greater than 2, less than 2 mm is LVMD, that is further divided into micromets, 0.2 to 2 mm, that we designate PN1, MI, micromets. Below it, less than 0.2, isolated tumors designated with PN0, I+. Although still it is under refinement process, there is no standard protocol how to manage ultra staging, but it improves your diagnostic accuracy of sentinel lymph nodes. So there are 2 protocols of ultra staging, either MSKCC or MD Anderson. Ultra staging by MSKCC, when HEN is negative, you subject it to sectioning, 2 slices of a node. If you do 3 slices of a node, it is MD Anderson ultra staging. So risk factor for lymph node metastatic low volume metastatic deposit are LVSI and poor histopathology and myometric invasion greater than 50. If your ultra staging is positive, it upstages the disease. So what is the procedure of your SLNB? During anesthesia, 1 of the vial of ICG contains 25 milligrams of ICG. It should be reconstituted with 10 ml of sterile water and drawn in a syringe. The cervix injected at 3 and 9 o'clock position, 0.5 ml each, superficially first, 1 to 2 mm depth, then go deeper inside, around 1 centimeter, give another 0.5 ml on both sides, 3 and 9 o'clock. After giving it, you follow the MSKCC algorithm. Should be followed in all false negative cases. You see first peritoneum, see serosa, then evaluate retroperitoneum. If remove all the sentinel lymph nodes with a dye, remove all suspicious lymph nodes. If mapping is done, all algorithms completed. If you're still not able to find anything, to site-specific lymph node and para-aortic dissection, depending on the surgeon's discretion. Few more trials. Another is Centaur trial. Their objective is to examine the diagnostic accuracy, performance, characteristics, and morbidity associated with sentinel lymph nodes using ICG in patients with intermediate and high-grade endometrial cancers. Inclusion was stage 1, grade 2, high-grade endometrial cancers, grade 3, serous carcinosarcoma, clear cell, undifferentiated mixed, then scheduled for lab/robotic assessment. Exclusion was very early disease, low risk, grade 1, stage 1, endometrial cancer, advanced endometrial cancer, prior surgery, NACT, pregnancy, iodine allergy. Primary endpoint were assessment of sensitivity of slnb algorithm in detection of METs. Secondary endpoints were diagnostic accuracy, false negative rate, negative predictive rate, site-specific detection rate. So results of the study are: sentinel lymph node detection rate was 97%, sensitivity 96%, false negative rate 4, negative predictive rate 99. So in almost all studies, the detection rate is always more than 95%, sensitivity around 95 on all studies, and false negative rate is around less than 5 in almost all studies. So what is the outcome of the study? The central trial was planned to prospectively evaluate the diagnostic accuracy of sentinel lymph node using ICG, had accepted the diagnostic accuracy compared with lymphadenectomy for detection of lymph nodes disease in high-grade endometrial cancer. And from the study, it appears it is a valuable option for the staging of both early as well as high-grade endometrial cancers. Other studies, FIRES trial, they compared sentinel lymph node to lymph node dissection in endometrial cancers, multicentric study. Also, they studied same sensitivity, NPV, false negative rate, but using a robot assisted fluorescence. It is that Firefly technology, only robot in fireflies. So inclusion was stage 1, exclusion is same as that above. So the dye is almost same. They followed the MSKC algorithm, and they had almost 385 patients. Among 385 patients, Fire trial, 86 means 293 patients had successful mapped patients. 41 among those had a positive nodes. So sensitivity of evaluation was 97%, NPR is 99%. It didn't identify METs in 3% of the population. Another trial is SHREC trial. This is pelvic lymph node dissection in high-risk endometrial cancers, aim to evaluate the diagnostic accuracy, anatomically defined sentinel lymph node ICG, overall algorithm, in short, to see the sensitivity and this applicability of these nodes. So the SHREC trial showed 257 patients, 54 had pelvic lymph node METs, 54 were correctly identified with sensitivity 98%, NPR 99, no adverse resection, safely replaced, and they at the end postulated that it can safely replace the full lymph node dissection. So this is all about sentinel lymph node if it comes in endometrial cancer.
एडवेंटिशिया और T4 जो है दैट इज इन्वेजन टू द एडजेसेंट स्ट्रक्चर्स. इसमें A एंड B मतलब मैं ऐसा याद रखती हूँ कि A है PPD प्लूरा पेरिकार्डियम डायफ्राम, तो इन तीनों को इन्वेड हो जाए तो वो T4A रिसेक्टेबल होता है. T4B है अवे, ये नहीं रिसेक्ट हो सकता है, तो AVA दैट इज आउटा वर्टेब्रल बॉडी एंड एयरवे. सो T4B कैन नॉट बी रिसेक्टेड. Nodal stages में N1 है 1 to 2 lymph nodes, N2 है 3 to 6 lymph nodes, N3 है more than 7 lymph nodes. M1 M0 हमें पता है. Grading में well moderately and poorly differentiated. Location जो है, location only plays a role in the stage grouping of squamous cell carcinoma. इसमें हम L से जो है upper middle and lower define करेंगे. Upper जो होगा that will be cervical esophagus से लेकर lower border of azygous vein, middle होगा lower border of azygous vein to lower border of inferior pulmonary vein, और lower esophagus होगा lower border of inferior pulmonary vein to the stomach including the GE junction. ठीक है, ये हमने TNM क्लासिफिकेशन किया. अब जो उनका जो प्रोग्नोस्टिक क्लासिफिकेशन आया दैट इज स्टेज ग्रुपिंग, वो 3 टाइप का है. एक है क्लिनिकल प्रोग्नोस्टिक स्टेज ग्रुपिंग, एक है पैथोलॉजिकल प्रोग्नोस्टिक स्टेज ग्रुपिंग, और एक है नियो एडजुवेंट वाली. ठीक है, पोस्ट नियो एडजुवेंट. सो मोटा मोटा इसमें जो चेंजेस हैं वो मैं बता देती हूँ कि दोनों बेसिकली स्क्वामस और एडिनो अलग अलग तरह से स्टेज हुए हैं, और जो लोकेशन हमने पहले डिस्कस किया था, लोकेशन सिर्फ स्क्वामस की स्टेजिंग बदलती है. ठीक है, तो पहले हम पढ़ रहे हैं क्लिनिकल प्रोग्नोस्टिक स्टेज ग्रुपिंग. इसमें देखो मोटा मोटा जो चेंजेस है ना वो यही है कि स्क्वामस की जो स्टेजिंग है ना इट विल ऑलवेज बी a little better. That is, अगर हम क्लिनिकल प्रोग्नोस्टिक स्टेज ग्रुपिंग देख रहे हैं तो स्क्वामस में if we can see that T1, N0 या N1, अगर N1 स्टेजिंग भी है क्लिनिकल तो स्क्वामस में it is still stage 1, but a nodal metastasis N1, वही T1 N1 जो है एडिनो में स्टेज 2A में आ जाता है. ठीक है, सिमिलरली जो N2 है, N2 डिजीज है। N2 डिजीज जो है वो स्क्वामस में अभी भी स्टेज 3 में है, लेकिन कोई भी N2 डिजीज अडीनो में स्टेज 4A में आ जाती है। ठीक है, सो क्लिनिकली स्क्वामस की जो स्टेजिंग होगी इट विल ऑलवेज बी अ लिटिल बेटर ऑफ। ठीक है, क्लिनिकली। पैथोलॉजिकल स्टेजिंग में वी नो दैट स्क्वामस और अडीनो में जो है एक डिफरेंस जो है वो ये है कि लोकेशन क्या होगा। लोकेशन की जो डिस्टिंग्विशिंग है वो लोकेशन की डिस्टिंग्विशिंग सिर्फ स्टेज 2 पैथोलॉजिकल स्टेज 2 से इफेक्ट करती है। पैथोलॉजिकल स्टेज 1 में लोकेशन इफेक्ट नहीं करती। पैथोलॉजिकल स्टेज 1 में भी यही रहेगा जो हमने डिस्कस किया था कि स्क्वामस की स्टेजिंग विल बी अ लिटिल बेटर। क्यों? क्योंकि स्क्वामस की स्टेजिंग सिर्फ 1A और 1B है, अडीनो की स्टेजिंग 1A 1B 1C है। ठीक है, इसमें जो है स्क्वामस की स्टेजिंग में 1A पैथोलॉजिकल प्रोग्नोस्टिक स्टेजिंग में हमने किया कि कोई भी जो है ग्रेड जैसे T1A ग्रेड 3 स्टेजिंग जो है वो अभी भी 1B में है, लेकिन अडीनो में ग्रेड 3 आते ही वो 1C में फॉल कर जाता है। सो इट इज कंपैरेटिवली अ लिटिल वर्स देन स्क्वामस। एंड स्टेज 2 जो सबसे इम्पोर्टेंट है पैथोलॉजिकल स्टेजिंग में, क्योंकि इसमें लोकेशन वेरी करती है लोकेशन वाइज, कि स्टेज 2A जो है स्क्वामस का दैट विल बी 2A विल बी लोअर, अपर और मिडिल ऐसे डिवाइड होगा। इसमें लोअर वाला जो है वो बेटर ऑफ होगा, दैट इज T3 N0 M0 NEG, वो लोअर इसोफेगस उनमें पहले क्लासिफिकेशन में आता है एज कंपेयर टू अपर या मिडिल। अपर और मिडिल जो है प्रोग्नोस्टिकली 2B की तरफ ज्यादा जाता है, लोअर वाला थोड़ा अच्छा प्रोग्नोसिस है। सो पैथोलॉजिकल स्टेजिंग में डिफरेंसेस जो है वो सिर्फ 1 और 2 तक है। स्टेज 3 और स्टेज 4 की जो स्टेजिंग है स्क्वामस और अडीनो की वो बिल्कुल सेम है। ठीक है, सिमिलरली पोस्ट नियोएडजुवेंट स्टेजिंग भी है, वो भी स्क्वामस और अडीनो की बिल्कुल सेम है। दैट इज T0 से लेकर T2 तक अगर नोडल मेटास्टेसिस नहीं है और M0 है तो वो स्टेज 1 में आता है। T3 ऑनवर्ड्स जो है वो स्टेज 2 चला जाता है। कोई भी नोड आ गया दोनों में तो वो स्टेज 3 हो गया, और N3 M1 T4B ये सब स्टेज 4 है। ठीक है, तो जो स्क्वामस और अडीनो की डिस्टिंग्विशिंग है वो सिर्फ क्लिनिकल है। क्लिनिकल के अलावा पैथोलॉजिकल में भी सिर्फ स्टेज 1 और स्टेज 2 में है, और जो लोकेशन है वो सिर्फ पैथोलॉजिकल स्टेज 2 स्क्वामस को डिफरेंशिएट करती है। ये मोटा मोटा है, बाकी आपको थोड़ा सा देखना पड़ेगा बीच में। फिर एक और क्वेश्चन आता है सीवर्ट्स क्लासिफिकेशन पे। तो सीवर्ट्स क्लासिफिकेशन एनसीसीएम में जो अब दिया है दैट इज सीवर्ट 1 जो है वो कि अगर एपिसेंटर ऑफ द ट्यूमर है दैट इज अडीनो। पहली बात तो सीवर्ट क्लासिफिकेशन इज ओनली इंक्लूडिंग द एडिनोकार्सिनोमा ऑफ जी जंक्शन। सीवर्ट 1 और 2 वो इसोफेगस की तरह देखते हैं आप एनसीसीएन, और सीवर्ट 3 जो है वो गैस्ट्रिक की तरह देखते हैं। सो सीवर्ट 1 जो है दैट इज एडिनोकार्सिनोमा ऑफ लोअर इसोफेगस व्हिच इज having an epicenter 1 to 5 centimeters above esophagogastric junction. Sievert 2 जो है that is 1 centimeter above to 2 centimeter below, और Sievert 3 है subcardial with tumor epicenter between 2 centimeter to 5 centimeter below esophagogastric junction. और डेवटा यही कहती है कि जो Sievert 1 और 2 है आप उसे esophageal cancer की तरह स्टेज करो। बट एक नया अपडेट है, I found it in a Japanese study, तो that update says that Sievert 1 we know that आप transthoracic esophagectomy की तरह आप उसे handle करो। Sievert 3 should be handled as an extended total gastrectomy. Sievert 2 का classification में they have included two things. If a tumor is Sievert 2, so first you will look at the esophageal invasion. Esophageal invasion कितना है? If esophageal invasion is more than 3 centimeters in a Sievert 2, we will go for Ivor-Lewis esophagectomy plus upper and middle mediastinal lymphadenectomy. But अगर invasion less than 3 centimeters into the esophagus है, then you will further look at कि gastric invasion कितना है. So esophageal invasion less than 3 centimeters with a gastric invasion of less than 1/3 of stomach, then we will go for extended proximal transhiatic gastrectomy with lower mediastinal lymph node dissection. अगर invasion more than 3 centimeters with gastric invasion of more than 1/3 of stomach है, then we will go for extended total transhiatic gastrectomy with lower mediastinal lymph node dissection. But then again, बहुत सारी studies हैं, even Japanese classification says that all of the 3 modalities are acceptable. We can do a gastrectomy and esophagogastrectomy. मतलब limited resections और total gastrectomies के अंदर तीनों में से कौन सा बेटर है ये अभी तक नहीं डिफाइन हुआ है। फिर there was a question on Barrett's esophagus. So Barrett's esophagus is intestinal metaplasia in columnar line epithelium, जो कि normal squamous epithelium of distal esophagus को replace कर लेता है. Prevalence जो है that is 1.5% in general population. In asymptomatic patients जो है prevalence is 1.5%. तो ये दो फिगर्स जो हैं that is absolute risk of development to adenocarcinoma is 0.12 to 0.33%. And it is single most important factor for development of esophageal adenocarcinoma, and it has a relative risk of 11.3. So it can be short segment or long segment Barrett's esophagus. Both of them have a risk of development of dysplasia and further adenocarcinoma. दो टाइप के म्यूटेशंस जो पता चले हैं, एक पॉलीमॉर्फिज्म्स है TBX5 एंड GDF7, और दो सिंगल न्यूक्लियोटाइड पॉलीमॉर्फिज्म्स है RS3072 एंड RS270110. सो ये जो है एनकोड करते हैं ट्रांसक्रिप्शन फैक्टर्स को जो कि इन्वॉल्व होते हैं थोरैसिक और इसोफेजियल डेवलपमेंट में, और इनकी जो म्यूटेशंस है उनसे जो है इन्फ्लेमेटरी रिस्पॉन्स होता है एंड दे कैन लीड टू बैरेट्स esophagus. सो the strongest disease pathways जो हमें पता चला है that is by mesenchymal development और muscle cell differentiation से जो है ये pathways इन mutations है और इन pathways से जो है Barrett's esophagus develop होता है. So prevalence जो है सब में differ होगा. अगर general population, what we just said कि general population asymptomatic undergoing endoscopy will have a prevalence of 1.5%. किसी को रिफ्लक्स सिम्टम्स है तो 2.3%, लेकिन अगर किसी को रिफ्लक्स सिम्टम नहीं है तो 1.2% जो है देयर इज अ प्रेवलेंस ऑफ Barrett's esophagus. सो although American College of Gastroenterology or American College of Gastrointestinal Endoscopy recommends selective screening of patients with GERD and multiple risk factors for esophageal cancer, but this is unlikely to have any significant impact on reducing the death of the patients because 40% of the patients will not have these reflux symptoms. So all the US medical societies recommend surveillance endoscopy for patients with Barrett's esophagus, लेकिन endoscopy का जो interval है that will depend on the degree of dysplasia. So अगर low grade dysplasia है तो endoscopy should be done 6 monthly for the first year followed by annual endoscopy. This is अगर हम लोग कोई endoscopic eradication नहीं कर रहे हैं Barrett's का. High grade में हमें more frequently करना होता है, that is every 3 monthly screening, जिसमें अभी तक eradication नहीं किया गया है. कीमो प्रिवेंशन के जो है एक ही ट्रायल आया था that is एस्पेक्ट ट्रायल. इट वाज अ phase 3 RCT. इसमें एस्पिरिन और एस्मोप्रोजोल कीमो प्रिवेंशन के बारे में बताया गया था. सो वी इवैल्यूएटेड द इफेक्ट ऑफ हाई एंड लो डोज ऑफ एस्मोप्रोजोल विद एंड विदाउट लो डोज एस्पिरिन on progression of Barrett's esophagus. Endpoint था time to all cause mortality, esophageal adenocarcinoma development and high grade dysplasia development. Median follow up इस स्टडी का था 8.9 years. ये months नहीं है, 8.9 years है, sorry. So findings इसके थे कि high dose PPI is superior to low dose PPI in progression. Aspirin से जो है strongest benefit पता चला था, and aspirin का जो effect है that is additive in protecting against the composite endpoint. तीनों endpoints के लिए aspirin and high dose esomeprazole are acting as composite. So there is another new update that is cytosponge trefoil factor 3. So basically high risk Barrett's के साथ there is a challenge कि उनका compliance इतना poor होता है कि वो बार-बार नहीं आते हैं. So एक pre endoscopy screening tool है that is cytosponge trefoil factor 3. इससे जो है it allows for evaluation of mucosal cells on an outpatient setting. कि patient आएगा, ये trefoil factor खाएगा, and then जो sample collect किया जाएगा उसके बाद it has a high predictive value क्योंकि जो sample produce किया जाएगा, so वो उसपे mucosal cells होंगे which will be predictive of development of dysplasia. So 1654 patients were assessed और उनमें जो sample थे उनमें 231 patients में positive result आया था, and after a follow up of 12 months so these patients who had a positive result were sent for endoscopy, and after 12 months a lot of these patients, more than half of these patients had Barrett's esophagus. So there was a significant difference of 18.3 per 1000 person years between the two groups. So cytosponge trefoil factor 3 is a pre-endoscopic treatment. It is a pre-endoscopic intervention. So this screening may be better to identify patients in need of endoscopy. सो ये सब है, कीमो प्रिवेंशन हो गया और हमने हाई ग्रेड लो ग्रेड के बारे में देखा। सो अगर हाई ग्रेड डिस्प्लेजिया है, सो हाई ग्रेड डिस्प्लेजिया के मैनेजमेंट में पर ईयर कैंसर इंसिडेंस है 6% एंड वी हैव टू डू अ थेरेपेटिक इंटरवेंशन फॉर हाई ग्रेड डिस्प्लेजिया। सो पहले इसोफेजेक्टमी बोला जाता था बाय ओल्डर सीरीज कि हम इसोफेगस ही हटा देंगे तो ट्यूमर नहीं बनेगा। क्यों? क्योंकि 40% पेशेंट्स में अनआइडेंटिफाइड ट्यूमर था जब इसोफेजेक्टमी की गई थी, बट देन इट वाज सेड कि 60% लोगों में तो ट्यूमर नहीं है ना। सो एंडोस्कोपिक मेथड्स, क्योंकि अब छोटे मतलब इनवेजिव ट्यूमर्स एज एन T1A ट्यूमर्स के लिए भी एक्सेप्ट किया जा रहा है। सो एंडोस्कोपिक मेथड्स जो है दे वर एक्सेप्टेड फॉर हाई ग्रेड डिस्प्लेजियाज। सो एंडोस्कोपिक मेथड्स आर ऑफ टू टाइप्स, अब्लेटिव एंड एंडोस्कोपिक रिसेक्शन। So ablative methods में mechanism is destruction of the mucosal layer. तो mucosal, so it is a composite thing. अगर mucosal injury होती है और साथ में acid controlled environment मिलता है along with the PPI, so it will eliminate the pre-malignant mucosal cells. It will resurface esophageal lining with the squamous epithelium, and it will also decrease the risk of progression to high-grade dysplasia and adenoma. 3 टाइप के एब्लेटिव मेथड्स हैं, फोटोडायनेमिक थेरेपी, लेजर एब्लेशन एंड रेडियो फ्रीक्वेंसी एब्लेशन। फोटोडायनेमिक थेरेपी जो बेसिकली इनएक्टिव फोटोसेंसिटिव एजेंट को यूज किया जाता था, उसे लाइट को एक्सपोज किया जाता था जिससे ऑक्सीजन फ्री रेडिकल्स बनते थे, बट दिस हैज फॉलन आउट ऑफ फेवर नाउ। लेजर एब्लेशन या आर्गन प्लाज्मा कोएगुलेशन भी हाई ग्रेड डिस्प्लेजिया को टारगेट करने के लिए यूज किया गया था, बट इसमें जो है इन्वेजिव कैंसर प्रोग्रेशन रेट ज्यादा फाइंड किया गया। सो अब जो प्रेफर्ड एब्लेशन टेक्निक है दैट इज रेडियो फ्रीक्वेंसी एब्लेशन, और ये भी हम सिर्फ नॉन नॉड्यूलर बैरेट्स इसोफेगस में यूज कर सकते हैं। सो ये था अब्लेटिव। अब रिसेक्शन। सो रिसेक्शन जो है इट इज इम्पोर्टेंट, क्यों? बिकॉज ये हमें डायग्नोस्टिक स्टेजिंग के लिए भी टिश्यू देता है। सो इट कैन बी यूज्ड फॉर हाई ग्रेड डिस्प्लेजियाज और सुपरफिशियल इन्वेजिव कार्सिनोमास। सो ये फर्दर EMR एंड ESD टाइप का है। EMR जो है हाई ग्रेड डिस्प्लेजियाज एंड कार्सिनोमास लिमिटेड टू म्यूकोसा, दैट इज T1A, इट इज एन अल्टरनेट टू इसोफेजेक्टमी। एंड ESD जो है it is basically it was examined for a very small group of patients, and it was also found to be useful in limited invasive esophageal cancer, that is T1B, submucosal invasion सिर्फ SM1 तक. So it was found to be safe and effective with a favorable 5-year results in properly selected patients. But T1B SM2 में esophagectomy या फिर definitive CTRT was found to be much better than ESD. ये डेविटा के हिसाब से है, बट NCCN स्टिल सेज दैट T1B या डीपर ट्यूमर हो तो वी शुड गो फॉर इसोफेजेक्टमी। फिर एक और क्वेश्चन था, दैट इज ट्रांसथोरैसिक इसोफेजेक्टमी के प्रोज एंड कॉन्स। सो ट्रांसथोरैसिक इसोफेजेक्टमी इज द मोस्ट कॉमन सर्जिकल अप्रोच एंड इट इज द स्टैंडर्ड अप्रोच अगेंस्ट ऑल द टेक्निक्स आर मेजर्ड। सो प्रोज है इसके, ऑफ कोर्स हमें डायरेक्ट विजुअलाइजेशन मिलती है, देयर इज अ वाइडर डिसेक्शन, मोर रेडियल मार्जिन, हायर लिम्फ नोड यील्ड। बट कॉन्स है कि पेशेंट्स जिनमें कोमॉर्बिड कंडीशंस ज़्यादा होती हैं, दे हैव अ हायर कॉम्प्रोमाइज ऑफ कार्डियो रेस्पिरेटरी फंक्शन, पेरीऑप मॉर्बिडिटी ज़्यादा होती है, इंट्राथोरैसिक अनास्टोमोसिस ऑल्दो लीक रेट्स कम हो, बट अगर होते हैं तो मीडियास्टिनाइटिस, सेप्सिस एंड डेथ का चांसेस बढ़ जाते हैं। However, when it was compared between transthoracic and transhiatal esophageectomy, overall survival and state-specific survival were similar. So, जो भी हमने स्टडीज पढ़ी हैं between transhiatal and transthoracic, transhiatal has a higher incidence of anastomotic leak. It has higher incidence of stricture, recurrent laryngeal nerve injury, vocal cord palsy, increased ventilatory support, increased ICU time. Whereas transthoracic has increased peri-op morbidity, higher pulmonary complications, higher 30-day mortality rate, but there is no difference in radicality of procedure in terms of R0, R1 or R2 resection, or median disease-free survival and overall survival, local, regional and distant recurrence में दोनों में कोई difference नहीं है, transthoracic है, transhiatal है। There was this another question, minimally invasive esophagectomy. Minimally invasive esophagectomy में जो हमें वो मांगे गया था, evidence मांगे गए थे. So there are 6 trials which are mentioned. सबसे पहला जो है that is Luketich जो है that is a comparison between 3 incision versus Ivor Lewis minimally invasive. So they compared ICU stay, and length of stay. So and उनमें ICU stay was 2 days, length of stay was 8 days. State-specific survival was similar to open esophagectomy and they found it was a safe approach. उसके बाद था time trial. So time trial was minimally invasive esophagectomy versus open esophagectomy. They found that minimally invasive esophagectomy was associated with statistically significant decrease in pulmonary infection. Length of stay, there was no difference in R0 rates, lymph node retrieval rates. Moreover, minimally invasive techniques से there could be decrease in pulmonary infection and length of stay, decrease blood loss. फिर टाइम ट्रायल का जो है एक लॉन्ग टर्म वो भी आया था, लॉन्ग टर्म रिजल्ट्स उनमें भी आया था कि 3 years के बाद भी ओवरऑल सर्वाइवल एंड डिजीज फ्री सर्वाइवल में कोई डिफरेंस नहीं है. So there was a recent meta-analysis of 48 studies जिसमें minimally invasive and open में भी there is a decrease in hospital mortality, decrease in pulmonary complication, decrease in pulmonary embolism और AR का rates भी कम होते हैं minimally invasive techniques में. फिर मीरो ट्रायल, सो मीरो ट्रायल बेसिकली कंपेयर कर रहा था कि हम अगर सो इसमें थोरासिक जो है उन्होंने अभी भी ओपन किया. सो दे डिड अ ओपन राइट थोरेकोटमी, सिर्फ जो गैस्ट्रिक मोबिलाइजेशन है वो लैप्रोस्कोपी की थी और दे कंपेयर्ड इट विद ट्रांस थोरासिक ओपन एपिसोफेजेक्टमी. They found there was no difference in 5-year overall survival, disease-free survival, but there was statistically significant difference in major intra-op and post-op pulmonary functions and higher quality of life फंक्शन था उसमें मिनिमली इन्वेजिव में. फिर अब जो है एक है रोबोट ट्रायल, रोबोट 2 ट्रायल एंड रामी ट्रायल. रोबोट ट्रायल जो था दैट इज ओपन वर्सेस रोबोटिक. So robotic was associated with decrease in surgical complication and improved quality of life. There was no difference in length of stay, overall survival, disease-free survival. So last के जो 2 trials हैं ये conventional minimally invasive as in bats वर्सेस रोबोटिक को कंपेयर कर रहे हैं. सो रामी एंड रोबोट 2 जो है ये दोनों कंपेयर कर रहे हैं रोबोटिक वर्सेस कन्वेंशनल मिनिमली इन्वेजिव. सो इन दोनों में भी सो रामी जो था इट वाज including only squamous cell cancers. इनमें there was no difference in short term complication, long term complication, R0 dissection rate and 90-day mortality. Robot 2 अभी भी open to acute है, इसमें SCC नहीं है, इसमें अडीनो है, अभी तक इसके रिजल्ट्स नहीं है. फिर ये कुछ पॉइंट्स हैं NCCN गाइडलाइंस के. सो अकॉर्डिंग टू NCCN गाइडलाइंस सीवर्ट 2 या सीवर्ट 3 में लैप्रोस्कोपी डूइंग अ लैप्रोस्कोपी विल हेल्प इन डिटेक्टिंग रेडियोलॉजिकली ओकल्ट डिजीज. अब पॉजिटिव पेरिटोनियल साइटोलॉजी जो है इन द एब्सेंस ऑफ फ्रैंक पेरिटोनियल मेटास्टैटिक इम्प्लांट्स is suggestive of a poor prognosis and a positive peritoneal cytology should be considered as M1 disease. T3 clinically T3 and N positive disease अगर है तो उनमें पहले लैब स्टेजिंग होनी चाहिए, पेरिटोनियल वॉशिंग्स भी होनी चाहिए. मल्टी स्टेशन बल्कि लिम्फेडेनोपैथी अगर है तो यूजुअली अनरिसेक्टेबल हो जाएगा पेशेंट. बट दिस मल्टी स्टेशन लिम्फेडेनोपैथी शुड बी टेकन अप with considerations taken of the age, performance status and response to therapy. और esophageal junction cancers में अगर supraclavicular lymph node है then that also becomes unresectable. And esophagectomy without induction chemotherapy we need minimum of 15 lymph nodes. After pre-op radiation minimum optimum कितने चाहिए वो अभी तक नहीं पता, but we should aim for as same as the upfront one, that is 15. फिर esophagectomy complications पे questions आए. So esophagectomy complications can be divided into systemic complications, that is जो cardio and pulmonary complications हो सकते हैं. Conduit related complications जिस पे हमको mostly question आया, that is anastomotic leak, conduit ischemia and anastomotic stricture. ये 3 जो है conduit complications है. Recurrent laryngeal nerve injury, chylothorax जिस पे question आया हुआ है, and functional disorders that includes delayed gastric emptying, dysphagia, reflux and dumping. So conduit complications are mostly driven by ischemia and denervation, and whenever we do laser Doppler function perfusion and whenever there was a decrease in laser Doppler function perfusion, it was associated with increased breakdown, increased stricture, increased functional disorders. So anastomotic leak जो है उसका rate है 5 to 40%. और anastomosis के अलावा perianastomotic leak भी हो सकता है, that is from gastric staple line और tip necrosis. Factors बहुत सारे हो सकते हैं जैसे technique of anastomosis, location of anastomosis, type of conduit, location of conduit, degree of devascularization and ischemia. So thoracic anastomosis is less prone to leak, but if it leaks it is associated with a more morbidity. मैनेजमेंट ऑफ एनास्टोमोसिस लीक डिपेंड करता है if it is a cervical or a thoracic anastomosis. Cervical anastomosis में we have to drain, that is the most important. Endoscopic stenting can be required. Thoracic anastomosis leak में it may also require re-exploration. Endoscopic stenting can be done, but it is often associated with stent migration. Transluminal bag or myocutaneous flaps can be used for managing thoracic leaks. काइलोथोरैक्स पे क्वेश्चन आया हुआ है. सो काइलोथोरैक्स की रेट्स ऑफ इंजरी बेसिकली thoracic duct injury का रेट है 0 to 8% in esophageectomy. Mortality is as high as 18%. 30-day major complication rate is 85%. So there was a study which studied the impact of prophylactic ligation of thoracic duct. It was a retrospective study of 1800 patients. It did not decrease the incidence of chylothorax. Also, on a multivariate analysis, it was found to have a significantly worse long-term outcomes as compared to non-ligation. So, diagnosis कैसे करते हैं काइलोथोरैक्स को? So basically increase in chest tube output जब भी enteral alimentation शुरू होता है, and change in output from a serosanguinous to a milky discharge. Pleural fluid triglyceride should be more than 110 milligram per deciliter, and there could be presence of chylomicrons. If either of these are there, it is diagnostic of chylothorax. Management. So first we'll have to eliminate enteral nutrition, TPN, chest drain output observation, octreotide fluid resuscitation. Short course of conservative management can be given. It is warranted. But if the leak is more than 10 ml per kg for more than 5 days, the conservative management will mostly fail. So an early surgical intervention is warranted within 14 days. Because if not done, it is associated with a high mortality associated with immunological and nutritional depletion. If now we are taking the patient for surgical approach, so right thoracotomy with conduit retraction and thoracic duct ligation with or without lymphangiogram can be done. And source identification. For source identification, 25 cc of cream or veg oil can be given enterally via feeding tube 6 hours prior to procedure. The point of leak can be identified and proximity and distally can be ligated. If leak site is not identified, ligation of all the tissue.
हेलो, अरे बिजी हैं अभी, बाद में फ़ोन करते हैं, कुछ अर्जेंट है? अरे पढ़ रहे हैं, कुछ क्लास चल रहा है. हम 2 बार फ़ोन नहीं उठा रहे तो समझ जाओ ना, कुछ इमरजेंसी है.
मैनेजमेंट में अगर बिनाइन स्ट्रक्चर है, वी कैन गो फॉर एंडोस्कोपिक डायलेटेशन विद बलून या सैलरी डायलेटर्स. दिस इज डन एज सून एज डिस्फेजिया प्रेजेंट्स एंड इट कैन बी रिपीटेड एज ऑफन एज नीडेड. अगर रेकरेंस आया है एनास्टोमोटिक साइट पे, सो इट इज रेयर एंड रिसेक्शन विद डाइवर्जन कैन बी डन. रेकरेंस उस पर भी डिपेंड करेगा कि कितने सादा रेकरेंस है. इफ इट वाज ओनली स्मॉल रेकरेंस एंड ओनली लोकल रेकरेंस, resection with anastomosis can be done. However, if it is a huge resection, if it requires huge resection, complete esophagogastrectomy can be done with colonic imposition. फिर एक और complication that is associated with this is RLM injury. It is seen mostly in cervical anastomosis. So whenever RLM injury is suspected, laryngoscopy or swallow should be done. Management is temporary middle vocal cord medialization. So अगर temporary से जो है, if the patient on temporary vocal cord medialization has not recovered, it may also lead to a need for a permanent vocal cord medialization. ये जो लास्ट में है दैट इज दैट रीसेंट अपडेट पेपर जो मैंने देखा था, बट अभी भी सारी स्टडी से बोलती है कि तीनों मेथड्स में से C1-2 के लिए कोई भी सुपीरियर नहीं है, कोई भी किया जा सकता है. बस यही.